This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2018, all rights reserved. My name is Shauna Strickland. I am a respiratory therapist and Associate Executive Director at the AARC. I welcome you to today's presentation, Reducing Harm from Respiratory Depression Associated with Opioids. Upon completion of this AARC webcast, participants will be able to provide an overview of the Hospital Quality Institute's toolkit, describe the steps organizations may take to assess the current state of their respiratory depression prevention processes, outline each phase of the respiratory monitoring care process and risk mitigation strategies described in the toolkit, and provide an overview of the current respiratory monitoring technologies available. I am pleased to welcome Mr. Kevin McQueen. Kevin is a registered respiratory therapist and is board certified in patient safety. He holds a master's degree in healthcare administration and currently serves as the Director of Respiratory Care and Sleep Diagnostics for the University of Colorado Health System in Colorado Springs. In his past roles, he has served as an Environment of Care Officer, Patient Experience Director, Risk Manager, and Patient Safety Officer. Kevin has authored and co-authored a number of articles and toolkits, primarily focusing on patient safety and respiratory care topics. He has also been active with the AARC as chair of the patient safety community. Kevin has no relationships to disclose. I disclose that I am a paid employee of the AARC. Brand names of products and/or medications may be mentioned only as examples of technology. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis and to provide information and education regarding the availability. Kevin, welcome to the program.
I'd like to start off the presentation by saying good afternoon to everyone on the call, of course with the exception of my friends on the West Coast where it's only 11 o'clock. I want to thank you all for joining me in this presentation because this is a topic that's dear to my heart. We're going to be doing a quick overview of the 2017 Hospital Quality Institute's National Toolkit titled Reducing Harm from Respiratory Depression in Non-ICU Patients Through Risk Mitigation and Respiratory Monitoring. Now, this was a large-scale project that was monitored through the Hospital Quality Institute in the state of California. This is a collaborative effort with numerous hospitals throughout the state where we shared a common goal of trying to improve patient safety and reducing risk. The main purpose of the toolkit really was to design a simple-to-use method for hospitals across the country to have an easy access to evidence-based and best practices on how to improve assessment, monitoring, and interventions for any patients that they have in their organizations that are receiving opioids or other sedation effect medications that could cause unrecognized respiratory depression. So why was the toolkit created? Well, I think everyone on the call is well aware that our nation continues to have a problem across the whole globe, of course, is that we have preventable adverse events occurring in hospitals. Patients are harmed, not intentionally, but unintentionally we are causing harm to patients by any type of medical error. Some studies have said 200,000 to 400,000 patients actually lose their lives attributed to medical errors, and that 2 to 4 million cases of serious injuries occur. I've been in healthcare for about 32 years, and I've experienced, I'd say, way too many incidents where I've seen patients harmed by something that we could have avoided. This concern is so great that back in 2012, the Joint Commission published a Sentinel Event Alert, number 49, that was really outlining the concerns about postoperative and opioid-induced respiratory depression events that were occurring in hospitals across the nation, and that they were seeing that patients were significantly harmed or worse, had lost their lives. The Anesthesia Patient Safety Foundation back in 2011 also published information stating that preventable deaths and permanent brain damage were occurring related to opioid use when we weren't properly monitoring the patients or assessing them. What I've seen throughout my career, though, especially since I've been in risk, is that many organizations are well versed in knowing all this, but taking that knowledge and converting it to actually doing changes or mitigations in practice to prevent the potential for harm has been a little slower than some people would wish. So really the idea of the toolkit was to bridge a nice gap between the knowledge of knowing these risks and what we need to do to prevent the harm to the patients. A little bit of background history about the HQI toolkit. Back in 2013 in San Diego, the San Diego Patient Safety Council was designing one of multiple toolkits, and it was called Respiratory Monitoring of Patients Outside the ICU Guideline Care Toolkit. This was a toolkit that was created with 8 San Diego area hospitals all working together to create a similar idea of what we do with the HQI toolkit. Once the toolkit was released in 2014, some of us that were on the council went out and toured the country and gave lectures about what was in the toolkit. I had the great pleasure of discussing the toolkit in Tampa at the ARC Congress. And once that toolkit had been out for a couple years, that's when we were approached by the Medtronic's Patient Safety Foundation and asking if, since the toolkit had been out for a few years, if we were interested in publishing a revised, updated version of it. So in 2017, the Hospital Quality Institute decided to start working on bringing together hospitals throughout the state of California, since the San Diego Patient Safety Council is no longer together due to budget changes. So after several months of advertising the project throughout California, we were able to pull together 10 hospitals that wanted to participate. And on your slide, you can see many of the contributing authors, and I just wanted to kind of talk a little bit about some of the individuals. First one is Patty Atkins, and she is the Vice President of Quality and Patient Safety for Sharp Hospital in San Diego. She has been the project leader on both of the toolkits, and her amazing leadership is what helped us get through the endless hours of working on this project. Also, Alicia Munoz, who is the Vice President of Regional Quality Network for Hospital Quality Institute. She helped us lead this through this project and keep everybody going in the right direction. So as you can see from the list, we had 10 hospitals. We also had the California Hospital Association Medication and Safety Committee, and CHPSO, which is the California Hospital Patient Safety Organization, which helped us work on this project. As you can see from the list, we also had several respiratory therapists involved. It truly was a multidisciplinary project. We had physicians, nurses, pharmacists, several respiratory therapists, patient safety, quality, risk management, and research experts. I wanted to shout out to Gwendolyn Butler. She's from Kaiser Permanente up in West Los Angeles. Zay Lopez, he's a respiratory therapist I've worked with for many years, and he's at Palomar Health in San Diego. Mary Kay Sennings, who's with Barton Healthcare up in Lake Tahoe, beautiful Lake Tahoe. She's well known with her efforts around preventing respiratory depression. George Silva, he's a respiratory therapist. Again, I've worked with many years in San Diego. He's with Prime Healthcare. And Lori Wenzel, she's with Sharp Hospital in San Diego. So all of us got together and started talking about, one, the original toolkit and how we wanted to move forward and what we'd start working on. to make it as easy as possible for hospitals to use this toolkit to not only create a brand new program if they currently do not want to have it in place, but they could also use the toolkit to shore up or strengthen the one they currently have. I also reached out to other experts, and many of the team did, including Dr. Frank Overdyke, because of his immense knowledge in the field. So what were our goals of the toolkit? Well, number one is to prevent the sentinel event alert that the Joint Commission we're talking about. Really, the main thing that we want to do is make sure that hospitals across the country are not causing serious harms to patients associated with respiratory depression surrounding opioid administration. We also wanted to decrease adverse medication events. Every time a patient is found where they're having severe respiratory depression or struggling, this is a medication event. And this is something that will add a lot of work and stress not only to the hospital and the staff, but also to the patients involved. Potentially reducing lengths of stay. So if an adverse event is serious enough and causes any harm, even if it's temporary, there's a potential that the patient will end up having to stay in the hospital longer. Another one that's a big concern is avoidable transfers to higher level care. So the patient's coming in for a simple surgical procedure, has an adverse event following the surgical intervention, ends up being transferred to the intensive care unit and staying for several days. Another one we looked at is increasing compliance with policies and procedures. And this is something that the team truly believed that we could improve upon if we helped hospitals design better and safer processes around assessment, monitoring, and interventions if something goes wrong. Number 6 was reducing pharmacy costs. Though these are not huge, the unplanned use of Narcan or other medications to reverse the situation or treat the patient or any laboratory testing adds cost to the care. Being that I worked in risk management and patient safety, definitely concerns about reducing malpractice and any fines that could happen from state agencies, Department of Health. But really, the number one concern is always patient safety and preventing harm. But every organization does have a responsibility to protect itself from losing financial resources due to medical errors. And last, overall increased patient and family satisfaction by avoiding preventable harm. The reason why I originally got involved with the San Diego toolkit was I was working in risk management as a patient safety officer at my last organization, and we had a gentleman who had postoperative pain from having a spinal fusion done, and during his postoperative care, he was a very unusual case. He was in his early 40s, very healthy individual, no medical comorbidities, but he had a surgical procedure earlier in his life called a Nissen fundoplication, which left him unable to vomit. He became nauseated following the surgery, and he was making retching sounds that were, to the nurse, they sounded horrible, and he seemed to be very uncomfortable. When the nurse started treating the patient, he had a PCA pump on, so he was receiving opioids. The physician had ordered strong muscle relaxants because of the surgery on the spine. The nurse gave him anti-nausea medications because of the retching sound and that he was nauseated from the pain meds. Then she gave him some anti-anxiety meds because he was getting so anxious. So I'm sure everyone on the call can just imagine what a wonderful cocktail this was with all of these medications that produce respiratory depression or sedation effect. This situation was brought to my attention because his wife was in the room and he was not being monitored by any physiological monitoring devices. And when he started to relax, the nurse, after she gave him the last dose of medication, when he started to relax, the nurse said, "Look, it's good." To the wife, "He's starting to relax. I think, he's going to calm down and get some rest now." She went out of the room, And after about 20 minutes, the wife ran out to the nurse's station and said that her husband was making horrible sounds, horrible snoring sounds, and wasn't breathing adequately. And in the end, we were easily able to revive the gentleman. He did not have a cardiac arrest or a respiratory arrest. He just had respiratory depression. But it upset him and his wife so much because of the fear that what if she would have left the room? What if the wife had stepped out? Since we had no monitoring capabilities on the patient, how would we have known that the patient was heading toward respiratory failure and possibly respiratory arrest? So after working with this patient and his wife, following up the event, I made a promise to him and his wife that I'd do everything I could to prevent any future occurrence of this type. And lo and behold, that was right when the San Diego Patient Safety Council was starting to work on the 2014 toolkit. So I got involved in it, and truly it's been a passion of mine ever since. And one of the biggest things that I've learned about that one is truly not to go by outcomes bias. This gentleman did not, again, have a respiratory arrest. He did not have a cardiac arrest. But the possibility that he could have was enormous. And the reality is that patients throughout the organization, any organization in the country, could run into this same type of situation. So when the HQI team got together and we started working, first thing we wanted to do was create a shared vision for all of us. And this is something that I believe, as we talk throughout this presentation about the toolkit, I'll talk about not only how HQI did the steps, but how your organizations could also. So in creating the vision for this, we read all the literature, and it showed us some pretty alarming stuff. One was the study showed us that about 90% of opioid-induced respiratory depression was possibly or probably preventable with easy, better monitoring. And there was a lot of discussion on our team what the word monitoring means. So is monitoring physical assessment using your eyes and looking at the patient, or was it electronic monitoring with devices? And the reality is we realized that it was truly both. Our biggest goal with this project was to make sure that we could help organizations really create a passion for the organization to better their programs to reduce the risk. And one of the biggest steps in doing this is how do we encourage staff or motivate staff throughout the organization towards these safer practices. And that can be challenging because we all know anytime we come up with a great new idea, a new process or a new plan or a new policy, many staff see this as something that's adding work to them. So if we're asking them to do more assessments, or we're asking them to click more boxes, ask more questions, or put a monitor on a patient, respond to any alarms, sometimes you're going to get some pushback. And we really, truly have to find a way to make patient or care providers as passionate about this and willing to do the extra steps to protect their patients. So one of the ways we do that is by using stories about patients that were seriously harmed or worse, lost their lives due to respiratory-induced depression. Back when we created the first toolkit in San Diego, the story that we used was a young girl named Leah Kofel. Her mother, Lenora Alexander, came and spoke to our team and told us the story about her beautiful, healthy 11-year-old girl that underwent elective surgery at a very well-known and prestigious California hospital to repair or correct a chest deformity that the poor girl felt uncomfortable with. The good news is the surgery was successful. She came through it. The sad part is during her recovery, the child required such strong opioid painkillers. She was getting fentanyl at such large dosages that she became very sedated. The child kept being upset, very, very uncomfortable, and the mother and father were both at the bedside, working with the care providers. After about 30 hours, the husband decided to leave, and one of the things he said to the care providers when he left is he was concerned that his daughter was over-medicated. And one of the residents said to the father, well, if you won't allow me to give her more pain medications, allow me to give her something for anxiety. And so this resident decided to order this 80-pound, 11-year-old 2 milligrams of Ativan. And the child finally settled down, and Lenore, the poor mother, said she finally fell asleep next to her daughter after 30 hours of being awake. And a few hours later, when she woke up, she realized Leah had passed away and was dead in bed lying next to her. And I've worked with Lenore several times, both on the toolkits and with the patient safety movement. And she is an extremely passionate woman who's had the most tragic, horrific event that could ever happen to a parent. I'm a parent of 4 kids. I can't even fathom what this poor mother went through. But what she has done is she has spent the remainder of her life, and I believe she will spend the remainder of her life, pushing for patient safety changes, especially around monitoring of patients for respiratory depression. This story about Leah really helped not only myself, but I believe every single person on the team. So when we went ahead and started working on the HQI team, Lenore had spoken to me at the last patient safety movement symposium that I was at, and she said, Kevin, if you work on this toolkit again, I just pray that you'll keep telling the story about Leah and keep the team moving forward. So truly, the story about Leah Kofel was a driving force in the creation of the new HQI toolkit. So once we got the toolkit plan or project rolling, we started to break the teams down. We selected 4 primary sections that we need to work on. So we put together 4 teams with different facilitators. What the teams did is each one of the groups went out and investigated every current practice that they could find. So did a tremendous amount of literature researches, looking for best practices, any evidence-based recommendations, consulted with thought leaders throughout the industry, throughout healthcare, people that have tremendous knowledge on how to reduce respiratory depression surrounding opioids or other sedation medications. The team also looked at what was the current medical devices that are available. When we first published the San Diego version, there were fewer monitoring devices available, but as we got closer to the 2017 model, we were able to see other, sorry about that, my microphone moved, other devices that were coming out on the market that could also help organizations better monitor patients for respiratory depression. One of the recommendations with HQI is that we tell hospitals, please, to make sure that you put together a really well-designed multidisciplinary work group when you're looking at all your policies, processes, any standards, or anything that you have to do with opioid administration and how you do assessments. So make sure to include respiratory therapists, the nurses, pharmacists, physicians, anyone that's involved with any part of the process. We really recommend that you bring them in. Next thing we did is we pulled the teams together and started discussing what we found. We reviewed all the literature. The teams gave presentations to each other about what they found from their research. We looked at in-house best practices. So we looked at some of the industry leaders when it comes to patient safety, some of the best practice hospitals. We discussed a lot about lessons learned. When we did the first toolkit, and even when I remember rolling this out with an amazing team at my previous hospital, we went through a lot of lessons learned. There were a lot of speed bumps, challenges, and things that we had to overcome. We looked at different hospital protocols and tried to find ones that were as easy to use but yet as effective and focused as possible. We looked at especially physician order sets and how they're designed. We looked at different tools to help and any issues or barriers. Once we did that, the teams wanted to vet all the information. And what we were looking at is, were the things that we were going to put in the toolkit targeted solutions that will truly help organizations to reduce the risk? Were they focused for the different areas that hospitals will meet or will have challenges? Were they actionable items that people could actually do? Were they meaningful, practical, so they were not overwhelming? Because if we made it too complicated, people wouldn't do it. Were they evidence-based whenever possible? And were they appropriate to the level of what we needed? Once we did all the review, the teams got together, and this is truly a consensus publication. So what we're telling people is this is not the HQI toolkit is not an evidence-based 100% tool. It is a consensus of different multidisciplinary specialists and experts in the field that have reviewed the literature and tried to put together the best possible decision-making processes for organizations to use. The next area I want to talk about, and this is truly my passion because of being in risk and patient safety, is conducting risk assessments. So this can be for organizations that are just starting their process, or it can be for hospitals that have had their processes going for some time, but they just want to do a risk assessment to see how it's coming along. So some areas that truly suggest the review are, one is incident reports. So working with risk management and looking at any incident reports that were put into the system related to incidents of respiratory depression or any other adverse events that could be contributed back to the opioids or other respiratory depressive meds. You can reach out to your legal offices and look at closed claims data. This would be any claims that were related to respiratory depression, and then you'd be able to look and see if it had anything to do with opioids or any other medications. Also, pulling reports on non-planned use of naloxone or Narcan. The two hospitals I worked with lately, I was able to get this easily through the pharmacy. The biggest thing is to make sure that it is non-planned Narcan uses and not reversal agents that physicians are planning to use. There are some physicians that post-procedures like to use Narcan to reverse the patient quickly. This will definitely tell you if you're lucky enough not only to get the number of non-planned, but if you can get where the locations are that the non-planned are used. And a lot of times if you have a system similar to Pyxis or other supply control systems, you can find out where the Narcan's being pulled from. An area that sometimes can be challenging but can provide tremendous information is working with rapid response teams or MET teams and looking over cases for respiratory depression, altered levels of consciousness, or over sedation. Literally, this may take some hand review, literally face-to-face review of the charts, but it allows you to start seeing where, again, these calls are occurring and how often. Also looking at specific patient populations. So look for pain management areas, any kind of post-operative units where they end up using larger doses of opioids or other pain management methods. Patients on PCA pumps is a big one. Patients with obstructive sleep apnea, any areas that do procedural sedation, areas that you commonly will use or find patients with fentanyl patches or any kind of neurological impairment. So looking at those people out, putting them on spreadsheets and knowing where these patient populations are can help when you fine-tune your plan. Specific unit design, this is also one. Some people ask us why the toolkit has it in the title that it's in non-ICU areas. And that's because when we look at adverse events, majority of them happen outside the ICU. In the ICU, the patient-to-nurse ratios are lower, and they're usually on multiple monitors so that if something is to occur, people are going to catch it quickly and be able to react to it. Where we see problems are especially post-operative units or units where they have really long hallways, these long distances away from the nurse's station, or units where they don't use any kind of physiological monitors. They're not on pulse oximeters, they're not on end-tidal CO2 or heart rate monitors. These are where we see problems. In addition, a physical risk assessment can include, again, looking at the care units, finding out how they're laid out, how well they can hear alarms to the nurse's station. We have a spreadsheet that we use at University of Colorado here in Colorado Springs, where we literally looked at the designs of the units. Do they do moderate sedation? Do they provide even higher levels of sedation? Do we do IV push narcotics? Do we have certain neuro patients that are ventilated that we need to monitor how well they're ventilating? Everywhere that we use PCA pumps. One of the things that we did is we pulled the pharmacy usage to get the average number of PCA pumps used every day. And then we went for the peak high number, how high was our highest number. And between using that information, it can really help when you're looking at how many of the physiological monitors you need. Example here, we do about 30 PCA pumps a day. If you are looking at monitoring minimally 24 hours post the start of the PCA pump, you'd need 70 to 75 monitors readily available so that you could have enough rotation to be able to cover those patients and have enough for the next day. We also look for patients where we have them when they have obstructive sleep apnea, how we assess those patients, assess all the units to see what other monitoring they're using. So are they using heart rate, SpO2? Are they doing ventilation monitoring either by end-tidal CO2 or by minute ventilation monitoring? Then we counted the equipment needed. So you do an assessment of if we're going to add end-tidal CO2, pulse oximetry, heart rate, any other monitoring, is it something that we just need to add to the bedside monitor as another module, or do we need standalone units? Do we need them to be just assigned to the unit, or do we need them assigned to an area like biomed or SPD where they're rotated throughout the hospital similar to PCA pumps? We also do assessment of the types of interfaces that are used, nasal cannulas, endotracheal tubes, looking at what kind of interfaces you'd need in those areas so that when you design your plan, you can also put in soft product costs. In the end, you can come up with a number of devices needed. Hopefully, you will cover all areas that have PCA pumps, areas that use IV push, or other areas where they do conscious sedation. Big area of challenge is staff education. Because this is not going to be in one single unit, this is going to be usually throughout many areas of the hospital. A well-designed staff education plan has to be worked out so that you can train them not only on the monitoring, but the assessments and how to intervene if there's adverse events. So staff education is a major area. Another area we looked at was alarms. So some devices only alarm at the bedside. So hospitals have to determine what they need to protect their patients. So if it's a very small unit with close observation, you might be very comfortable with just bedside alarms. If you have an area that's long drawn out throughout the hallways, far away from the nurse's station, you might want a device that not only alarms at the bedside, but also triggers the nurse call system, sends a message to the nursing station, to a system if you have it there, or to a central monitoring location. And some hospitals also want to look if it has the capability of doing escalation, where if someone doesn't respond to the alarm, it will trigger up to another individual higher up to be able to be the secondary or third backup to respond to the alarm. Another area that's important is, does it integrate with the electronic medical record? Probably one of the biggest pushbacks I've ever got from nurses is if the device doesn't send the information to the EMR. So knowing if the device is capable of doing that and if it's necessary. So going back to the toolkit, what we ended up working on as the team is putting together these 7 stages of the respiratory depression risk mitigation and monitoring process. So number 1 is assess and identify risk factors. So that's assessing the patients and identifying if there's risk factors that need to be worked or mitigated. The second thing that we worked on is implementing care plans to meet all those risk factors. Third phase is selecting the appropriate respiratory monitoring technology. So determining if you need an oxygenation monitor or a ventilation monitor, both, or multi-parameter. The fourth process was educating and engaging both the staff, family members, and patients. The fifth step is actually monitoring the patients. And 6 is making sure the staff know how to intervene in case there's adverse situations. So the toolkit takes all the different risk factors and breaks them down. And as you can see on this screen, I just took a small portion of the toolkit and put on there. But some of the titles are altered airway issues, increased sedation, decreased respiratory rate, decreased ventilation, impaired gas exchange, patient surveillance, barriers or environment. And what we did is took those problems or challenges and tried to make targeted risk reduction tactics to use. Example is increased sedation is if you're having to use these opioids, is whenever possible try to bring in pain management specialists or engage pain consultants to help better manage the pain. Use physician order management systems to make sure that you have single clear directions on the orders. And I'll talk more about those because the EMR and physician ordering can be very good or can be an extreme challenge. Looking at decreased ventilation, so bringing in positive pressure ventilation if necessary, engaging early mobilization, or making sure to continuously electronically monitor the patient for proper and adequate ventilation. Patient surveillance down at the bottom talks about being very good about instructing the patients and family members about the risk of turning off or taking off the devices for the alarms. Nurses should consider relocating the patients that are at higher risk closer to the nurse's station or where they can have better observation, or if necessary, we can use the horrible word that every C-suite can't stand to hear, and that is bring in a sitter to observe the patient, or use centralized remote monitoring. Another thing included in the toolkit is a really nice, simple tool that was created by Patty Atkins and her safety team at Sharp Hospital. It's called the California Opioid Assessment and Action Safety Tool. All of us on the project loved coming up with the acronym of COAST because we're on the West Coast at the time. But you can see it breaks down all those 7 challenges and has the recommendations underneath them. This tool can be for organizations to go through all their processes and look to see if they're meeting and working on each section of those risks. It can also be a simple tool where it's literally printed out and the nurse could circle all the problems that the patient has, all the comorbidities or any kind of risk factors, circle them and determine by the number of circles what the risk is, whether it's low, moderate, high. So it's a really simple tool. It's only been out since the release of the toolkit, so we'll definitely be interested in getting any recommendations or feedback from organizations as they go forward and try to use it. So, as I said earlier, it has the risk factors broken down to the 7 primary ones. And once you look at these different ones, the toolkit was nice and gives care plans that can be designed. So hospitals can literally take the information, they can expand upon it, do more things that are related directly to the organization, but it gives a good footwork of designing care plans surrounding each one of the problems or challenges. And since we really have to have patient-specific care plans, it's a great way to make sure that the organization is covering all the risk with the patients and providing safe care. One area that we wanted to make sure that organizations discuss, especially with their physicians, is making sure that they don't have one-size-fit-all pain management orders. And even at my previous organization, this was a challenge that was very large. Terry Vidal's, our amazing medication safety officer, helped us work on this with several physicians. When you sit down and ask physicians when they design care plans or orders, some of them will be very honest with you, and they'll say, I'm going to literally give you every option known to man so that you won't call me in the middle of the night. And sadly, we have to make sure that the bedside care providers and nurses providing for the patients realize that, because just because it's ordered does not mean it's safe to give it to the patient. And back to the patient I told you about that started my journey, where the nurse gave him the anti-nausea meds, the muscle relaxants, the anti-anxiety meds, and the pain meds. When we asked her, she was like, well, the physician ordered it. I believe he felt these were all safe. Following that event, our hospital gave tremendous education to all nurses that provide that levels of care about what happens when you mix meds that have sedation effect. So it's really important that when you're designing these order plans that it both treats opioid tolerant patients and opioid naive patients, and that it's just not one size fits all. It also should look at patients that have renal problems in the elderly and pediatric patients. Going back to Leah's situation where 2 milligrams of Ativan was a tremendously large dose for somebody that only weighed 80 pounds. So we just want to make sure that people are going out there and thoroughly looking at their physician orders, and that they're not one size fits all, that they are designed for the patient-specific care that they're providing. Selecting monitoring technology. So again, we talked about the fact that when the initial toolkit was designed, pulse oximetry and capnography were our two primary, and multi-parameter were our two primary physiological monitors. One thing that we really tried to get out in as much education to staff is the difference between pulse oximetry monitoring oxygenation, and that it's a late indicator, meaning that a patient can have respiratory depression significantly and they may not desaturate for a few minutes. And if the patient is receiving supplemental oxygen, their hemoglobin may stay saturated for a long time, even if they are to almost completely stop breathing. So getting that information out to nurses, knowing that pulse oximeters are not the solve-all and that it's the gospel. Capnography is very commonly used. It's a ventilation monitor. Allows us to look for effectiveness of ventilation, and it's an early indicator. It usually can tell us very quickly if the patient is not breathing adequately. The minute ventilation monitor, that's a newer monitor. It's FDA approved for adults, and it just got approved for children, pediatrics. We have tested the device. We found that it worked very well. ECRI Institute also tested the device, found that it works well. I tell individuals, if you're interested, definitely reach out and look at it. It is an option that's out there. And of course, multi-parameter monitoring. So multi-parameters, heart rate, SpO2, end-tidal CO2 allows much better monitoring for high-risk patients. We broke down the monitoring technologies in a little cheat sheet so that we could easily educate staff. Shows them a late indicator, early indicators, and what the devices can do. Very simple, easy for the staff to use. Engaging, coaching staff and patients. It's really the challenges of implementing any monitoring system. End-tidal CO2, the minute ventilation, is really working with the patients, talking to them preoperatively if ever possible, so they know what to expect when they're waking up. Tell them hopefully it's only on for a short period of time, 24 to 48 hours, but it's for their well-being and protecting them from any of the medications that we have to use to treat their pain. And repetitive education. So once the patient wakes up, is continuously telling them why the monitor is there, what they need to do if it alarms. End-tidal CO2, it can be as easy as just telling the patient, anytime you hear the alarm beep, you need to take 2 slow, deep breaths. That will usually reset most of the monitors. But really talking to the patients and the families to get them to understand how important it is to have this device on, and also talking to the staff. I also highly recommend that anytime patients or families truly refuse to use the electronic monitoring, that the staff try several times, but at the end they need to document thoroughly that the patients refuse even after being told the risk. Also, making sure that your processes have well-designed interventions if an adverse event occurs. Scott Griffiths is one of the amazing patient safety experts I've worked with through HQI on projects, and he always tries to tell you well-designed processes. Always look at where human factors occur, where humans will fail, and that you're going to build strong barriers to prevent human failure. You're going to build solid redundancy into your policies and processes, and that you're going to build solid interventions or rescues in case something goes wrong. And sometimes when I've worked with hospitals, I see that they do have Narcan, but it's somewhere that takes a few minutes to get to a reversal agent. So making sure that you have adequate reversal agents readily available for your staff so they don't have to go get them, have to get an order, have them pre-designed so that they can easily access them through the medication storage facilities so that you can instantly give it in case, and making sure that rapid response teams are well versed in it. Alarm strategies are another area, and we talked a little bit about making sure that you can escalate it up to make sure that your staff hear it at the area they're at, or that you have backup systems in place to make sure that somebody is monitoring either at a central monitoring station or at the nurse's station to make sure people respond in adequate time. Some of the devices are able to shut off additional dosage of opioids, which is also a nice thing to have. The toolkit does also provide some guidance for default settings on certain devices. We did not cover all devices, but there are a few that are well known out there that we have quick guides to help people reduce nuisance alarms. In the back of the toolkit it has lessons learned. So some of the examples are how to sell this project to your C-suite. So value analysis, benefits from cost avoidance. So this project will cost capital dollars. There's no question. It's not cheap, but there are cost avoidance related to the medical care, the extended stays, the rapid response calls, any lawsuits that may follow. Also using quality metrics of reducing the adverse events and the med errors. We also talk about purchasing considerations. We have some examples of policies, procedures, and protocols to help organizations that are new to this and standard order sets. So in summary, majority of opioid-induced respiratory depression is preventable if we do proper assessments and monitoring. Risk assessments are a powerful tool that can help hospitals create programs or processes around risk reduction and help better protect their patients from adverse events. Telling stories to your staff, especially about harm or serious injury or death, can help fire them up. It's a sad way to do it, but it definitely, if we tug at the heartstrings to get people passionate about why we have to do this, is so important. Utilizing the risk stratification tools can help to take appropriate actions to mitigate the risk. And utilizing the correct types of monitors in the right locations can be essential for a successful program. So anyone that needs to have access to the toolkit, it is readily available online. You can Google HQI respiratory depression. You can see the link there. Also, the ARC will have the link, I'm sure, readily available. But if you have any questions, I have my information there. If you need help with risk assessment tools or anything, please reach out to me. I'd be very happy to help you. Any questions?
Hi, Kevin. Thank you so much. The story of Lee always gets to me, and the sad part is, of course, that all of these are preventable. So we do what we can to assist, and we have a few questions, and then we'll get to your desired question of how easily or what challenges might be encountered when we try to implement this toolkit. So one of the questions that our attendees have is that their facility uses end-tidal CO2 monitors on their patients with PCA pumps, but sometimes the nurses decide that if oxygen isn't needed, they can take off the nasal cannula, which also then takes the end-tidal CO2 monitor off. So this viewer wants to know what you recommend in that case.
Well, that's truly a human factors thing that would be hard to put a barrier in. So I think on that one, it has to be frequent education of keep telling the care providers of the risks and why the devices are so important. I go out, I preach this endlessly everywhere I go, and that is the difference between oxygenation and ventilation, and the difference between pulse oximetry and end-tidal CO2, and why it's so important with these patients that are at risk for respiratory depression that we are monitoring them for ventilation, adequate ventilation. So making simple educational flyers and going out there and really talking to the nurses, making sure the respiratory therapists are promoting this. In most hospitals that I've worked with, the nurses truly do control the monitoring because the therapists don't need to go there to put a patient on a monitor when the nurse is already there. But the respiratory therapists are truly the consultants. We're the experts in ventilation, so we have to be the cheerleaders that go out there and preach to why monitoring is so important to prevent these adverse events.
Thank you, Kevin. I went ahead and brought up that toolkit link to keep on the screen for the duration of our Q&A, mostly so that if folks wanted to write it down, they could, and also to provide them with your contact information. But we will post that link with the archive of the webcast, so we'll have that paired up, absolutely. So one of the questions that folks have about the toolkit itself is how to implement. We've talked about what it involves and the recommendations and what that means, but if I'm a respiratory therapist who's sitting on this webinar today and I say, this is fantastic, I need to take this to my hospital and get it implemented, how can I, as a respiratory therapist, do that in my facility?
Okay, well, being that I was a respiratory therapist in my facility, of course I had the role as a patient safety officer, but I'm still a diehard respiratory therapist. It is one, the toolkit is free. Like I said, you could go to Google and just put HQI respiratory depression and it'll pop right up and you'll see the PDF right there. You can print out the toolkit, pull together a team, reach out to your risk management people, your patient safety people, and talk to them first. They will know and help you look at the risks. If you have a very healthy culture, your organization will already know this because they'll talk about their adverse events. Where the patients had respiratory depression and had Narcan given or had to go to the unit. So once you get them to start talking about it, then you can put together a multidisciplinary team and you just go through the toolkit and start looking at it and comparing it to your current processes. So assessing how do your risk assessments do, because there's a whole section on there about the different nationally recognized evidence-based toolkits, the RAS, the POS, all the toolkits. It tells you, or the tools, how to assess your patients for sedation level and post-operative if they're ready to leave the PACU. So you can go through there and look, what are we doing at our hospital? What does the toolkit say is the best practice? Does it meet our needs of our hospital? And then you can start working on creating processes. And it literally is, you could break it into sections. You can have one group working on the nursing care. You could have the pharmacy team working on all the medication orders and how they do those processes. And you can have risk management, patient safety work with you on doing the formal risk assessment of the organization. And then once you get it all back together, you just slowly work your way through it and come up with your justification. Because like I said, this does cost money, but it is so so worth it to prevent adverse events and any harm to patients.
And so getting a champion then, I would imagine, from all of the multidisciplinary teams would be beneficial as well, yes?
Yes. Find people that are passionate. Find a nurse that's very passionate on a floor that has dealt with this situation. Even better if it's a nurse who's ever had an adverse event that had any harm, that they are passionate to never see that happen again. Get a pharmacist that just loves creating tremendously safe processes around medication ordering, and work with risk managers that want to do everything they can. This is a big area of risk for hospitals, big enough that it's a sentinel event alert. So it's not one of those things where they can say it's a small problem. This is a big problem. Many hospitals have ongoing situations on a daily to weekly basis, but lucky enough they catch them in time. But you can't be outcomes biased. You can't sit there and say, well, oh, we've gotten away, we've no harm, no foul. It's always what is the potential risk to the patients that drives the desire to create better processes.
And I hate even bringing it up because, again, it's about the human life and not the money. But as one of our attendees has identified, the primary difficulty would be A, resistance to change, and B, financial cost. Have you had experience with people in positions of authority who have not seen the utility of this in relation to cost?
Yes, cost has probably been my biggest challenge. My last organization was a smaller community hospital. It wasn't a huge system, so finances are tighter. So what we did there is we did that risk assessment, and we went to what is our highest risk areas. So we bought it each year. We bought more and more of the monitors. Each year we added 15 or so of the monitors, and we started at our highest risk area. So we determined that our postoperative orthopedic floor was our highest risk. And any of our procedural areas, which every hospital should already have every procedural area covered by entitled CO2 because it's a requirement. But figure out what your highest risk is. If you have to do baby steps, do baby steps. But just keep doing them. Don't back off. Do your highest risk and then keep going. We start out with PCA pumps. And if you can say, okay, we're going to start PCA pumps, if that's what your organization finds in the risk assessment is their biggest risk and has had the most events, that's where you start with. If you find it's in your IV push areas, you start there. So it all comes down to the risk assessment to help you focus your efforts because cost is a challenge for all organizations.
Thank you, Kevin, very much for joining us today. This has been a phenomenal session.
Thank you.
And thank you all for joining us as well. We hope that you will join us again on April 16 for the April Respiratory Care Journalcast with Dr. Erin Light, and again on May 3rd as Susan Blonshine discusses the 2017 ATS ERS standards for DLCO. Again, thank you for joining us and have a great day.
Okay, everybody, that is all the time we have for today. Thank you so much, Kevin, for sharing your expertise with us today, and thank you also to all of our attendees for your participation. In just a moment, you will see a Submit Credit button on your screen. Please be patient as there is a high volume of attendees, so this may take a few moments to populate. If you are an individual who has registered for this program, you will go through the credit submission process on your individual account. Should this button not appear at all for you, please navigate to the Credit tab and select the Click Here button linked. If you are a group participant, please have your group leader submit your information in the Group Attendance tab to be provided with follow-up instructions on how to submit for credit. This concludes today's presentation. To end, simply exit out of your browser window. We hope you have a great afternoon.